folks, Alfie here at Vente Pain Relief Clinic. And today we've got another clinical tip and trick. Today we're going to talk about releasing neck spasms via using the junction of L5-S1 in the thoracic vertebrae. So this is going to be an interesting one. This is actually in two parts. So this is part one. I'm going to talk a little bit about the reasoning behind it, clinical presentation, so on and so forth. And the second part will be Skelly here, will be on the table. But I just want to mention, next week we are going to do a video, our first video, on working with the fascia. I love working with the fascia. I've got a lot of stuff to throw out there in terms of sharing what I've learned over the years working with the fascia. So that'll be very, very interesting. So as I mentioned, today we're going to take a look at releasing the neck, particularly when it's in spasm, using the junction of L5-S1 and the thoracic vertebrae. So let me just bring Skelly here forward a bit. As you can see, I've taped Skelly here on the thoracic spine from C7 down onwards here, and the area here L5-S1. And the reason why I taped it up is to indicate the areas that are so-called stuck or jammed. So we'll talk a bit about that in a while, but let's talk about the reasoning for using this method. So local neck treatments do minimal in terms of potential results at times. So you might be working on someone's neck spasm. They might come in the morning and say, wow, I woke up this morning with my neck in this position here, and I find it very painful when I turn my head. Sometimes what happens is that we work on it and we get minimal results. In fact, when I started working on spasms way back when, it was one of my problem treatments. I had difficulty with it. And I'm guessing many of you probably feel the same or have felt the same. So back to the reasoning. When certain joints become hypomobile, in other words, when they're not moving as well, because with the joints, particularly with the spine, there is some give. It's not like a gross movement like the elbow where you have like, like a large range of motion with flexion or extension. With the vertebrae, it's usually about 1 millimeter or so in terms of motion that you'll feel. What happens is that when an area becomes hypomobile, when it doesn't move as well, other joints above and below have to compensate for the lack of motion. So the idea is that, like when we're looking at the thoracic spine, when it's not moving well, or the L5-S1 segment, when it's not moving well, other segments have to accommodate that lack of motion. So in this case, we're looking at the cervical spine. When the thoracic area is not moving well, what will happen is you'll get more motion around the cervical segments. And when that occurs, you could potentially get muscle spasms from the excessive motion of the different segments of the cervical spine. So in essence, what I'm trying to tell you is that this presentation is a chronic presentation. So in other words, this person may have developed this sort of locked position with the thoracic spine, L5-S1, over time, and it's showing up in the C-spine as a spasm, as sort of like the last part of the symptom scale. So with the L5-S1, just to mention, the reason why it can be jammed is that the iliopsoas and the other hip flexors, if they're really tight, they will rotate the pelvis anteriorly and inferiorly and cause more of a lordotic curve. So I'll put Skelly here sideways, you'll see. So if you can visualize the increased curve of the lordotic, of the lumbar spine with that lordotic curve and the anterior rotation of the pelvis, you'll see that L5 and S1 tend to get wedged together. We're going to talk about the motion of the L5-S1 in a little bit. So a big reason why these individuals come in with these neck spasms, and part of the root of the issue is that they are probably sitting for prolonged periods, and they're not moving too much, their hip flexors are tight, and the thoracic spine becomes very, very stiff. Okay, so As mentioned before, the cervical spine, they might rotate, but there's more motion around the neck than what's normal for them. In terms of typical patient clinical presentation, okay, so this person has had a history of neck spasms every few weeks to a few months. So they'll tell you on the health history, or when you ask them, when do you get these spasms, they'll tell you, every few months, maybe every few weeks or so. And in fact, they may tell you also that the frequency, duration, and intensity of these spasms have increased over time. Potentially, they are unable to rotate the neck without discomfort. Right. So when they turn their head slightly, they'll tell you about it, that hurts. They may also show increased lumbar lordotic curve and kyphotic curve of the thoracic spine here. Patient may have slightly rotated, extended, and side bent neck postures, such as this. When they come in and see you, they may blame it on their sleep, and it could be from the sleep. But from your health history questioning and your screening, they'll give you more hints as to what is the primary reason, the predisposing reason for why they've come in. So when you're observing on clinical presentation, you'll notice that the C-spine range of motion is diminished, particularly rotation. As mentioned before, also, they will tell you that they sit for prolonged periods, potentially as part of their job. They're in front of the computer, typing away. And usually most people are at desk jobs these days. They also may feel lower back tightness, especially across the junction of L5-S1. So they might point to you that, yeah, I also feel my lower back is pretty tight. Or they might not even tell you. You might have to ask and say, do you have any other issues, such as lower back pain or lower back tightness? Also, they may feel tightness around the thoracic spine. Everything here feels jammed, it feels very sore and tight. May also have limited range of motion through the trunk. When they're rotating the trunk, they feel like they're not moving as well. They seem very, very limited when they turn right or left. So, in regards to assessment and reassessment, as mentioned, we check the range of motion before, during, and after. We also palpate for tenderness of the muscles of the cervical spine, so sternocleidomastoid, scalenes, trapezius, levator scapula, all those muscles you're going to palpate and see what is tender. Tenderness of the thoracic spine section of your erectors also. So that includes not only the thoracic spine itself, thoracic spine proper, but you're also looking at the muscles that lie parallel with the thoracic spine. Tenderness of sacrum, especially around L5-S1 junction. So sometimes what will happen is you'll poke in that area, L5-S1, and even in the sacroiliac joint, and you'll find there's a lot of sensitivity there. Motion of thoracic spine segments are limited laterally and anteriorly. So this is when the person's lying prone. When you're checking them, you're going to check to see how much motion there is anteriorly and also laterally of the different segments of the thoracic spine. Now, when you're doing this, you're obviously not going to go and start jamming away at the thoracic spine, but you're checking to see if there's much motion. Remember, it's only about 1 millimeter or so, maybe a bit less, but you will notice that relative to other segments, that there is a definite lack of motion in that area. Thoracic spine in general does not move as well as the cervical spine or the lumbar spine, but like I said, there is still a slight millimeter of give that you should be noting. Lack of separation between segments of L5-S1. You can feel this upon light traction of sacrum away from L5. So in a bit, I'll show you a demonstration in terms of how to go about doing that. This will be done prone. You should be able to note the motion that occurs around the thoracic spine as you're actually tractioning L5-S1. Lack of separation between thoracic segments and sacrum when sacrum has light traction on it. So again, you're going to notice a bit of the separation there. You're going to use your palpatory skills to see if there's any give in between each segment via the spinous processes. So we just talked a little bit about the reasoning behind it, and the clinical presentation, assessment, and reassessment. So this is basically part one. In the next part, we're going to have Skelly on the table, and I will demonstrate for you the actual things you will do to assess and reassess and see if things are moving. We'll see you in part two.